Welcome to this presentation, Top 10 Most Feared Diagnostic Errors for Radiology Trainees in Pediatric Neuroradiology Emergencies. I am Dr. Yu Dong Chen, and this session is based on content from the December 2024 issue of RadioGraphics. In today's session, we will explore the following: Introduction to the Challenges of Pediatric Neuroradiology, learning objectives to guide our discussion, the top 10 diagnostic errors in pediatric neuroradiology emergencies, including early cerebral edema detection, differentiating dural sinus thrombosis on non-contrast CT retropharyngeal edema versus early abscess, early shunt failure detection, craniocervical junction fractures versus normal ossification centers, calvarial fractures versus sutures, branchial cleft cyst versus retropharyngeal abscess, timing of heterogeneous subdural hematomas, porencephalic cyst versus ventriculomegaly, early orbital cellulitis detection, conclusions, and take-home points to summarize our findings. Introduction: Pediatric neuroradiology is a complex subspecialty that poses unique challenges, especially for radiology trainees. The developing pediatric brain presents dynamic imaging appearances, particularly during myelination. Pediatric pathophysiology and disease patterns differ significantly from adults. Limited exposure to pediatric imaging in training often exacerbates the difficulty of interpreting emergency cases. To address these challenges, senior radiology residents in the United States and Europe were surveyed to identify their most feared diagnostic errors during on-call shifts. This presentation tackles each concern through real-life cases, practical tips, and curated references to improve diagnostic confidence. Learning objectives: by the end of this session, participants will be able to 1. Recognize the imaging findings associated with the top 10 diagnostic errors in pediatric neuroradiology emergencies. 2. Understand factors contributing to these errors. 3. Apply practical strategies to minimize diagnostic errors in clinical practice. Case 1: Detection of early cerebral edema. Detection of early cerebral edema was identified as the most feared diagnostic error by 90% of surveyed trainees. Why is it challenging? Early findings can be subtle and easy to miss. Trainees may lack familiarity with the normal appearance of cerebrospinal fluid spaces in children. There is a fear of overcalling findings and reporting false positives. Practical tips to avoid missing early cerebral edema: focus on basal cisterns and cerebrospinal fluid spaces along the convexities. Build a mental reference of normal imaging findings by reviewing healthy cases. Remember that small structural changes can indicate significant pathology. When in doubt, prioritize patient safety by erring on the side of caution. Always integrate clinical history with imaging findings to improve diagnostic accuracy. A 14-year-old previously healthy girl presented with fever and seizures. A radiology trainee initially interpreted a non-contrast head CT overnight as showing no acute abnormality. Axial non-contrast head CT images are displayed. For comparison, age-matched normal head CT images are shown. Coronal non-contrast head CT images are displayed alongside age-matched normal head CTs for reference. The preliminary interpretation by the radiology trainee reported no acute findings. Key findings on reevaluation included effacement of brain sulci near the vertex, diminutive ventricles for the patient's age, and early effacement of basal cisterns. These findings, when compared with normal CT images, led to a final diagnosis of early cerebral edema and brain swelling. The patient developed rapid neurological decline, including non-reactive pupils, within 3 hours of the initial study. A follow-up CT was performed to evaluate changes. What are the main new findings? Follow-up CT demonstrated ongoing blurring of gray-white matter differentiation, further reduction in lateral ventricle size, complete effacement of basal cisterns, and pseudo-subarachnoid hemorrhage. New findings also included impending tonsillar herniation. A subsequent CT angiography revealed worsening malignant cerebral edema and increased intracranial pressure, evidenced by poor contrast opacification of the major branches of the circle of Willis. CSF analysis confirmed Streptococcus pneumoniae meningitis. Teaching point: in cases of unexplained rapid neurological decline, focus on the subarachnoid spaces and sulci near the vertex and basal cisterns. Subtle effacement may precede more overt changes, such as gray-white matter blurring or herniation. Case 2 detection of dural sinus thrombosis at non-contrast head CT. Dural sinus thrombosis was a feared diagnostic error for 73.3% of surveyed residents. Challenges arise due to its low pretest likelihood, vague clinical symptoms, and physiologic variations like dehydration in neonates, which may mimic thrombosis. Practical tips. Be vigilant in searching for dural sinus thrombosis. Quantify Hounsfield units. WHO, using regions of interest, and adjust for hematocrit levels. CT venography can confirm findings when the diagnosis is uncertain. Case details. A 12-day-old male, born at term with an unremarkable history, presented with new onset seizures. Initial non-contrast head CT findings were inconclusive. Roy analysis of Hounsfield units was performed, and normal age-matched head CTs were used for comparison. Teaching point. Reliance on visual assessment alone is insufficient. Actively measure Hounsfield units within the dural sinuses. A cutoff of 58, WHO, or an WHO to hematocrit ratio of 1.4, provides high sensitivity for detecting dural sinus thrombosis. Following initial non-contrast CT findings, the patient underwent CT venography, which confirmed the presence of dural sinus thrombosis. Treatment was initiated, and a follow-up Mr. Venogram confirmed complete resolution of the thrombosis. Key imaging findings included a non-enhancing filling defect, delta sign, within the superior sagittal sinus on the CT venogram, and restored blood flow in the sagittal sinus on the follow-up Mr. Venogram. Case 3 Retropharyngeal edema versus early abscess. Retropharyngeal edema versus abscess was a diagnostic challenge for 63.3% of surveyed residents. The distinction is critical due to its therapeutic implications. Retropharyngeal edema reflects lymphatic swelling and is non-drainable, while an abscess is an encapsulated, drainable collection. A 5-year-old boy presented with stridor and fever. A lateral airway radiograph showed prevertebral soft tissue thickening, and a neck CT with contrast material was performed. Preliminary interpretation reported a paratonsillar abscess extending to the retropharyngeal space. Imaging findings. The abscess was rim-enhancing, rounded, and lateralized. The retropharyngeal edema was bow-tie-shaped with no rim enhancement and relatively low mass effect. These findings were consistent with retropharyngeal edema with a paratonsillar abscess. Final diagnosis. Left paratonsillar abscess with extensive retropharyngeal edema. Teaching point. Edema lacks rim enhancement and shows a symmetric configuration, while an abscess appears rounded, asymmetric, and often causes significant mass effect. Case 4 detection of early shunt failure. Why is early shunt dysfunction challenging to diagnose? 1. Ventricular size changes can be subtle, especially in older patients with decreased cerebral compliance, where small changes may reflect significant intracranial pressure. 2. Patients with developmental delays often present vague symptoms and complex histories, complicating the assessment of intracranial pressure. 3. Distorted brain anatomy, such as in chronic hydrocephalus, or congenital malformations like Chiari-2, adds diagnostic difficulty. 4. Distinguishing chronic ventriculomegaly from acute hydrocephalus can be challenging due to overlapping imaging features. A 12-year-old boy with cerebral palsy and shunted hydrocephalus presented with headache and vomiting. Fast sequence MRI was performed. In comparison with prior imaging during a follow-up visit revealed subtle changes. What are the main new findings? Key findings included a subtle increase in the size of the left occipital horn of the lateral ventricle, better observed in the coronal plane. New partial effacement of sulci near the vertex was also noted. Final interpretation. Mild interval increase in ventricular size and sulcal effacement near the vertex, indicating possible shunt dysfunction. Teaching point. Always compare with prior imaging, as subtle changes in ventricular size and sulcal effacement are better detected in the coronal plane. Case 5 Craniocervical junction fractures versus normal ossification centers, craniocervical junction, CCJ. Fractures were a concern for 56.7% of surveyed residents. Challenges arise from unfamiliarity with normal ossification centers and fear of overcalling fractures. Practical take-home tips for prevention. 1. Study and familiarize. Learn about the imaging appearance of normal C1 and C2 ossification centers. It is important to learn from normal cases as well. 2. Understand pediatric craniocervical junction, CCJ flexibility. The CCJ in pediatric patients is substantially more flexible and has more physiologic laxity compared to adults. Fractures are very rare in infants and young children, with ligamentous injury being much more common. Indications for MRI of the craniocervical junction. MRI is useful for 1. Detecting subtle fractures by identifying bone marrow edema. 2. Evaluating ligamentous injuries. 3. Assessing chronicity of injuries. Differentiating acute fractures from chronic conditions. 4. Providing detailed images of soft tissues and neurologic structures. A 4-year-old boy with neck stiffness and no neurologic deficits underwent cervical spine CD. Initial interpretation suggested a probable non-displaced fracture of the anterior arch of C1. Final diagnosis: developmental variant of late anterior midline synchondrosis. Key points: C1 ossifies at 3 centers, with the anterior arch fusing at around 1 year of age. For C2, ossification centers include the dens, body, and 2 neural arches. Fusion occurs posteriorly by age 3, anteriorly by age 6, and at the base of the dens by age 12. Variants such as os odontoideum may mimic fractures. Case 6: calvarial fracture versus suture. A 2-year-old girl with head trauma presented with definite parietal fracture and questionable occipital fracture without scalp hematoma. Preliminary interpretation identified a fracture traversing the squamosal suture. Final interpretation confirmed non-displaced fractures of the left parietal and occipital bones. Follow-up CD 3 months later demonstrated bony fusion consistent with prior fracture. Teaching point: fractures typically have sharp, non-sclerotic borders, may cross sutures, and can cause diastasis. They may also show indirect signs like overlying soft tissue injury. In contrast, sutures are uniform in width, have a zigzag or interdigitated pattern, and lack associated soft tissue injury. Case 7: branchial cleft cyst versus retropharyngeal abscess. Branchial cleft cysts versus retropharyngeal abscesses were a diagnostic challenge for 36.7% of surveyed residents. A branchial cleft cyst may mimic an abscess when superinfected, but distinguishing the two is crucial for treatment planning. Practical take-home tips: focus on location to differentiate branchial cleft cysts. BCCs. 1. Typically lack inflammatory changes. 2. 95% are type 2, located posterior to the submandibular gland, anterior to the sternocleidomastoid, lateral to the carotid, caudal to the mandibular angle. A 10-year-old girl presented with neck swelling. Neck CD with contrast was performed to evaluate the lesion. Final interpretation: the lesion was identified as a second branchial cleft cyst, located posterior to the submandibular gland, lateral to the carotid space, anterior to the sternocleidomastoid muscle, and caudal to the angle of the mandible. A 12-year-old girl presented with neck swelling and torticollis. Neck CD with contrast material was performed to evaluate the findings. Final interpretation: the lesion was identified as a retropharyngeal abscess. It appeared medial to the carotid space, with extensive fat stranding, induration, and a thicker, irregularly enhancing wall compared to the typical branchial cleft cyst. Teaching point: abscesses exhibit features like surrounding fat inflammation, thicker walls, and reactive lymphadenopathy. A superinfected branchial cleft cyst may resemble an abscess on imaging, making clinical correlation essential. Case 8: time estimation of heterogeneous subdural hematomas. Time estimation of subdural hematomas, SDH, was a diagnostic challenge for 33.3% of surveyed residents. The difficulty stems from cognitive biases, medico-legal implications, and new insights into SDH pathophysiology, particularly in abusive head trauma. A 9-year-old girl presented with altered mental status after a fall. Initial non-contrast CT showed a heterogeneous subdural collection. Follow-up imaging 6 hours later showed no neurological decline. Teaching points. Differentiating acute from mixed attenuation SDH is often unreliable on initial imaging. Avoid terms like acute or chronic in early reports, focusing instead on attenuation patterns. If abusive head trauma is suspected, recommend MRI. Case 9, porencephalic cyst versus ventriculomegaly. Porencephalic cyst versus ventriculomegaly was a concern for 30% of surveyed residents. A 5-year-old boy presented with seizures, and non-contrast CT suggested entrapped right frontal horn of the lateral ventricle. Final interpretation. The lesion was identified as a right frontal porencephalic cyst connected to the right lateral ventricle. Features included increased subarachnoid spaces and midline shift towards the cyst due to volume loss. Teaching point. Porencephalic cysts result from prior encephaloclastic or destructive events, typically vascular in origin. Careful review of the medical record for prior hemorrhage, infarction, or prematurity is essential. Case 10, detection of early orbital cellulitis. Early orbital cellulitis was identified as a challenging diagnosis by 3.3% of residents. Key challenges include lack of clinical suspicion and limited multiplanar imaging, which reduces sensitivity for subtle findings. Practical take-home tips to improve sensitivity. 1. Carefully examine for signs of a potential superiosteal abscess. 2. Focus on the coronal plane when evaluating the orbits, as it provides critical details. 3. Always consider this diagnosis in children presenting with ophthalmoparesis and sinus disease. A 7-year-old girl presented with fever and left eye swelling. CT of the orbits with contrast material was performed. Initial interpretation noted moderate opacification of the paranasal sinuses. Imaging findings included myositis of the superior and rectus muscles with inflammatory stranding within the intraconal fat. Additionally, thrombosis of the left superior ophthalmic vein was detected as a filling defect on contrast-enhanced CT and MRI. Final diagnosis. Orbital cellulitis complicated by thrombophlebitis of the left ophthalmic vein and septic cavernous sinus thrombosis. Imaging showed filling defects in the left cavernous sinus with expansile borders and narrowing of the left internal carotid artery. Teaching point. Thoroughly review imaging in all planes, especially the coronal plane. Carefully assess the ophthalmic vein for thrombosis, as extension to the cavernous sinus can be life-threatening. Post-contrast imaging is essential for evaluating potential subperiosteal abscesses. Conclusions and take-home points. Key learning points include: 1. Early cerebral edema detection. Observe basal cisterns and sulci. 2. Dural sinus thrombosis. Perform quantitative analysis and adjust for hematocrit levels. 3. Retropharyngeal edema versus abscess. Assess enhancement and mass effect. 4. Early shunt failure. Use the coronal plane for reliable findings. Additional highlights: 5. Craniocervical junction fractures. Learn normal ossification timelines. MRI can aid in subtle cases. 6. Calvarial fractures versus sutures. Fractures may cross sutures and show diastasis. 7. Branchial cleft cysts versus abscesses. Consider location and inflammatory changes to differentiate. Final insights. 8. Time estimation of subdural hematomas. Avoid definitive time labels or use descriptive terms. 9. Porencephalic cyst versus ventriculomegaly. Consider mass effect versus ex-vacuole changes. 10. Early orbital cellulitis. Carefully evaluate the orbits in the coronal plane and use contrast for accurate detection.